And now, speaking of, well, not doctor, but certainly healthcare, let's bring in Fred Brown, our epidemiologist, who's been with us for, gosh, I think a year now. Fred,
Over a
you,
year, yeah.
yes, you joined us during when the pandemic took off, and so you've been keeping our audience up to date on what's happening with the variants and the vaccines and all sorts of stuff out there.
Yeah, I think our first discussion was late March, and then we had another one in April, and then we came in once a week for the last
Yeah, yeah.
over a
Well,
year now.
there's been so much, and last week we couldn't get it all in. I'm trying to remember exactly where we left off, but you were going to introduce some more data, but we just ran out of
Yes,
time.
we
So,
did. As that's which is too bad. How's everything been going? Good?
oh, good. Yeah. I mean, if I was any busier, I'd be chasing my tail, right? But I mean, that's better than the alternative. I'm Type A personality. I'm not much for sitting around, right? So.
Well, I've updated the material from last week, so much has happened. And if you let me share, I will
Oh, right.
show
Yeah, I
my
got to
screen.
hit that. Let me put my glasses on so I
Sure.
can see this here. I keep forgetting I got to do these things. Okay, you should be clear now.
Beautiful. Let's take a look here. See if I can. Uh, I think this is the right one. We'll take a look. This is the new Michigan opening policy. We'll start a little bit earlier than that, though. I wanted to show you a little bit about what's going on a worldwide basis, and then come down to where Michigan is on vaccinations, because
Okay,
vaccinations really
sounds
are going to,
great.
yeah, vaccinations are really going to drive our ability to hit herd immunity. So I thought we'd focus on that, and we will go to slideshow. And here we are. So basically, there are three big leaders in the world: Israel, United Kingdom, United States in vaccination, overall vaccination percentiles. And you can see that compared to Israel, Israel really went up the ramp a lot faster than we did. And then they petered out at about 60%. United Kingdom's went up the ramp also faster than we did. And then they are starting to peter out. And we are going up the ramps more slowly. And that slope of that line is very critical, because that indicates how fast we're getting to the point of a full vaccination situation in the United States. We need to get up. We need to get this line to be well over 70%. So you can see we're sort of halfway, possibly a little bit more than halfway. Of at least one dose of the COVID vaccine, and we're probably a third of the way there overall for the double dose, where we want to get to. So we've got a long ways to go, and maybe next week we can talk a little bit about what some of the rumors are that are occurring out there that are preventing people from feeling comfortable about getting vaccination, if you like. But you can see that our slope is slower. We're a little bit behind compared to the real leaders, and we're peaking out a little bit early. So hopefully our line continues and surpasses Israel and United Kingdom. Both Israel and United Kingdom, it's a little bit easier for them because they've got a national health system and very well coordinated national capabilities, and we do this state by state. So in some of our states, we're doing as well or better than the Israel and United Kingdom. Well, none of them better, but some of them close to as well in terms of penetration rates in certain parts of the country, like Northern California. But in most cases, we're lagging a little bit against the leaders. Now, here is what's happened as a result of that. As a result of that, you can see that while positivity rate, our positivity rate is close to 6% overall. And that's really high. If you think about 6% positivity rate, that means that we have to, if we want to do contact tracing, if we want to understand more about the disease state and regions, our systems will be overwhelmed. What we need to get to is about 1%. And at that point, you can start to contact trace. You can start to figure out what's going on historically with the vaccines, how it's progressing, what the real death rates are. Israel and United Kingdom are at that state right now. And you can see that they just kept going down, 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 and then flattened. We came down, but we're flattening at a rate that's similar to where we were back in September, which wasn't such a great period, frankly. So we're still worried about the fact that if we don't get enough of people vaccinated, that we're going to still create an opportunity for mutants and variants to come back and possibly penetrate the protection of the vaccine. And if that happens, we'll really see a spike because everyone will think they're protected and they won't be. So that's what we're worried about, especially next, not so much during the summer, but especially during the fall, winter period of the year. And you can see, again, if you look at the COVID case rating, case rates were plateauing at a very high level. We're plateauing at a level that we were, that actually we were back in October, November, where again, we were starting to come back up again. You can see Israel, United Kingdom, they really came down nicely and are staying down nicely. So that's the difference between having a third of your people protected versus 60% of your people protected. We don't really see a big vaccine impact until we get to at least 50%. Then we start to see some shift downward. Once we get to 60%, a very strong shift downward, and 70%, a very, very strong shift downward, as long as we're talking about a variant like the B117 variant. And we'll go into that in a second. And here's the hospitalization. And you can see that despite the fact that we've got a younger population than both the United Kingdom and Israel by about 10 years, we actually are a lot higher in terms of overall population rate. So just because you're young doesn't mean that well protected. It means you're a lot better protected than the older people, but we're still 5 times higher than the United Kingdom and Israel in almost every important category. And that's the difference in the vaccination rates and acceptance rates that we're seeing in the United States. And of course, our death rates also about 5 times higher. And unfortunately, in Michigan, we're going to get over the 20,000 mark shortly. And I'll get to that in a second. Here's where the different vaccines are being used. We have access, we're lucky, to the Pfizer, BioNTech, and Moderna vaccine. Those are the best vaccines in the world, bar none. And I'll show you the evidence for that in a while. You can see the other Oxford, AstraZeneca, less effective, but much broader usage rates across the world. The Sputnik 5, which is the Russian vaccine. Again, believe it or not, the Russian vaccine is actually the most approved vaccine in the world right now. Russia has more approvals per country than anywhere else in the world. But the major countries, the ones that you really care about, FDA, Japanese Health and Welfare, and EMA, which is the European Medicines Agency, have not approved it yet. So those are the big ones. And I think EMA's on the border of approving it based on some of the evidence we've got so far. And there's Sinovac and Sinopharm. Those are the 2 Chinese vaccines. We'll get into some of the politics that are going on right now. You can see the coverage, though, is quite a bit. We're getting to a point where we're covering parts of the world, except in one place, and that is Africa. Almost no one's been vaccinated. In India, almost no one's been vaccinated, with the exception of some Pfizer vaccines. And that's really scary. Yeah.
I don't see Johnson & Johnson listed on there. Is it still too early for worldwide distribution on that, or what?
No, J&J is just a smaller percentage. So J&J is on the list for both Europe, Europe and the United States. And the thing is, they're slightly less than 10% of the total vaccinations given. That'll increase because they only have the 1 dose. And here's the overall penetration rate. You can see the U.S.'s number is number 4. Chile is slightly better than us, and we'll get into some issues with Chile in a little while. And then you can see the issue we've got with the European Union. The European Union is getting together today to talk about, can't we all get together and have a nice, great tourist season? The answer is no, really you can't. You'll have a terrible time controlling the vaccine because you don't have enough vaccinations going on. I think they're going to try to finesse that. But if you're plan to go to Europe this year, I'm a Swiss citizen and a U.S. citizen. I'm going to wait before I go, because the more chances even though I've been vaccinated, the more chances you give, the more exposure you give to the new variants, to new environments, the better, especially long plane rides in closed areas, the better chance you've got of coming down with COVID, even despite vaccination. If you get continually exposed, you're one of these times you're going to catch it.
So that I shouldn't plan my trip to Amsterdam this summer, then next year, right?
Next year's better. Next year's better. Amsterdam, gosh, you can get that nice KLM flight straight from Detroit all the way through. So that's a little bit better.
I never do the connecting flights because I've had too many bad problems with those.
Oh yeah, the luggage. Yes. Yeah. Yeah, it goes one way, you go to another. Yeah, you try to avoid that, but that's a nice flight. And with Amsterdam, you might. I still think you'd be better off waiting until you're pretty sure that they've got their vaccination rates up at 50-60%.
Yeah.
Go over. And I'll show you why in a second. Here's European vaccination contracts. The problem with Europe is that they actually contracted with groups that don't have as much capacity and have had issues. And you can see the two red circles. Those are J&J and AstraZeneca. They've 1.6 billion doses that have been conditionally authorized. And unfortunately, AstraZeneca and J&J are having problems with clotting, as you know, about it's low single figure numbers per million that have an issue with this. With AstraZeneca, it's slightly higher than that. J&J, though, we've decided that, on a basis of safety, it's 1,500 times more safe to take the vaccine than to take the risk of getting COVID, versus the clotting issues that you've got in terms of getting a clot. So in terms of the worst possible scenario you've got with J&J is still 1,500 times better than if you take the risk of getting COVID, because COVID is a clotting disease. Ultimately, it's a microvascular disease. So you can see that unfortunately they've got all these planned to go ahead and get Europe vaccinated. And Europe, as you know, is slightly larger than we are. They're about 468 million people, as I recall. So you can get a sense of, right now they got Pfizer and Moderna available at 500 million doses, and that's only, they're really suffering because they need to have double that, and the other two are sort of on hold because of the coagulation problems, clotting problems, and then they haven't gotten approval for the last of all they've gotten authorized. So that's the issue with COVID. But you can see that at the end of Q2, they claim that they think they can get up to 68% vaccination levels at the end of this quarter. So, and on July 1st or so. So if you're waiting past July 1st, you should be at a pretty good level if Netherlands are actually able to make it, if we get the take vaccines out, and answer your question, right. Here is the data this is real world data from the United States. You can see we actually looked at 24 hospitals, 14 states from March, and we looked at people age 65 or older who are partially vaccinated. You are 64% protected. If you're fully vaccinated, you're 94% protected. So that 30% improvement in protection, it's well worth getting the second dose. Don't screw up and only take one dose. You're only half. You're going to lose 30% of the protective barrier of the vaccine, and you'll be less durable. It'll last less long.
Also, they're talking, Pfizer at least is talking about maybe a booster in the fall or something like that.
Yeah, and the reason for that is, I'll show you that in a second. It back to the variants, and I'll show you why we're going to probably need a booster in the fall. Now, interestingly, Serbia and Belgrade actually looked at the results after vaccination, and they found that you've got a 50 times lower risk of being hospitalized, a 15 times lower risk of getting pneumonia, because remember, this is a disease of the lungs, and an efficacy, apologize for the typo, of 92% in the real world in Serbia and Belgrade. Now, what's interesting about Serbia, Belgrade is they had deals with all kinds of manufacturers because they're having trouble with the AstraZeneca vaccine. And so they decided to get Chinese vaccines, Russian vaccines, and Pfizer vaccines. And here is the results they got. AstraZeneca infection risk is over twice as high as if you were to take Pfizer. And that's why it really does matter sometimes, in some instances, what vaccine you've got. And it's twice as good as the Chinese vaccine, and almost twice as good, about 80% better than the Sputnik vaccine. And you can see the reduction in pneumonia, which also is a big killer for the people who are elderly as well. So difference in the overall efficacy. People have been hesitant to show this because they're worried that people are going to ask for one vaccine versus another. Overall, it's relatively small on a absolute basis, but on a relative basis, it's considerable. And these were 18,000 patients, so it's a big study. So here, what's happening now, though, is you're seeing a lot of misinformation, and the misinformation is really being spawned by two groups. One is the Russians. They don't want us to vaccinate as fast because they want us to keep on our territory while they go and vaccinate the world. As I said, they have been approved in 52 countries, more than any other vaccine by far, and they are able to access 1.4 billion people. Now, that's a lot of people, and they're trying to use this as a lever in international politics. And they had only one article published indicating about a 92% efficacy, which is possible. They use a combination, remember, of the two adenoviruses. They actually combined the adenovirus from Johnson & Johnson and the adenovirus from AstraZeneca, just to make sure. And there, I was more worried about the safety issues of combining adenoviruses than I was of the efficacy. So I think it's possible they have a 92% efficacy. People are questioning whether they really do or not, because they were just rejected by the Brazilians for not being effective against the P1 variant, which is that variant that has which is awfully powerful because it has the what they call the EEC. I'll get into that mutation in a second. The Chinese are also really looking at this as a political game. And remember, they have Sinopharm and Sinovac immunizations, and they are much less impressive than the mRNA vaccines. They're very different. And the problem is that in the first dose you get isn't terribly effective. And so Chile, which shows, remember, they were kind of 60% vaccinated. They were number 3 in the country, in the world. The problem is that after the first dose, people were only about 16% protected, and they're only 67% protected after the second dose. So even though they're ahead of us over overall vaccination, in terms of protection rates, Chile is actually slightly behind us. So that's why you see that. And you can see the efficacy in the real world, 51 to 82% efficacy. Now remember, these are old technology vaccines. These have the coronavirus in them, and the coronavirus has been reduced, but they still have all the proteins of the coronavirus in them, and so they're also a little bit less safe, in my opinion, than the mRNA vaccines. So they're actually selling in advance. So Russia and China are saying to everyone, "Hey, we got this great vaccine," and they're actually doing their clinical trials in real time. If you buy the vaccine, you're putting I think you're putting your populations at a slight risk. And they're doing that because they want to beat the United States as a world leader in this space and start to create ties to people in the United States. And they're also promoting a lot of misinformation about our vaccines. Misinformation about fertility, which isn't true, misinformation about safety, which isn't true, misinformation about side effects, which aren't true, misinformation about the mRNA vaccine, which aren't true. So there's a lot of misinformation that's coming out that's being then hitting the internet and then being pushed forward by anti-vax movements, unfortunately. And so be careful about what you're reading, because a lot of this is becoming not just politicized in the United States, but politicized on a worldwide basis for political gain. CDC came out with some new mask guidelines, and you saw these. What's interesting is, if you haven't been vaccinated, don't plan to go to a movie theater. Don't go and worship. Don't go to indoor chorus events. Singing is the worst thing you can do with COVID. Shouting at people is the worst thing you can do. Don't eat at an indoor bar without a mask, and that's pretty hard to do. And you don't participate in high intensity exercise classes without a mask. That's also pretty hard to do. So if you don't get vaccinated, understand that the CDC is looking at this pretty carefully, and they're saying it's still really dangerous if you want to do these kinds of things and you won't be able to go back to life. And even if you're talking about relatively limited things like going to a hair salon, you're still at some risk. Uncrowded indoor shopping, museums, also at a level of risk. They're kind of giving you a yellow signal there. Watch and make your own assessment of how many people are around you. How ventilated the event is, especially if it's outdoor event, then it's much less to worry about. Indoor event, less so. And then finally, how much COVID you've got in your environment. So if you have a high amount of COVID, like we do in Michigan, these yellows turn to red. If you're not in such a high community spread area, then these yellows are more on the greenish side. So that's what the CDC is saying. It's not as obvious as some people would like, not as direct as some people like. And as a result of that, Michigan did something that was pretty inventive. Here's Michigan. And you can see that we're going to probably hit over 20,000 deaths. This means we will have killed off a city the size of Ypsilanti just on COVID in the last year. So goodbye Ypsilanti, right? That's a lot of people. That's 20,000 people. We're going to hit that number by the end of the month. And the reason we're going to hit that number is because we went through the peak of cases in the red dots, but we're still accelerated in terms of the number of black lines, which is the death rate in this slide. and that you can see from our last experience continues to accelerate about 5 weeks after the peak or so of the case rate. And here you've got the critical care groups are still very high, as high as they've ever been in terms of critical care, and on ventilators as high as we've ever been. So that's why Michigan has had this second phase, because we had the variants, because we had a lower rate of incidence of COVID in the past, because we were so protected. And because we do a lot of trading with groups like the UK and Europe, which have a lot of B117 variant in it. So here's where we are right now. The Michigan has said, we're going to base our results on our opening policy on how many people, what percent of your population is vaccinated. And this is the Governor Whitmer's announcement slide, and you can see that we want to get to 55% plus 14 days if we want to lift the requirement for employers to require remote work. Now we're doing about 30,000 injections a day. So if nothing falls off, we'll be there in about 20 days plus another 14 days. We'll be there in about 5 weeks. So we will, we'll get to 55% in about 5 weeks, which puts us in the, June timeframe, maybe end of June timeframe for step one. Step two, at that point, you're going to increase your capacity in more sports stadiums. You're going to be able to increase your capacity at exercise facilities. You'll be able to lift curfews in restaurants and bars. That's 60%. 70% means we're going to lift the gathering and face mask orders. That's what we're all hoping for, because it'll look like a lot more. If you do all the math at 30,000 vaccinations a day, we will get there around mid-September. So hopefully we can accelerate that so we can get there before school starts. We're getting the Moderna starting a new processes, a new clinical trial, as you know, for children as young as 6 months old. Pfizer should have the 12-year-old plus vaccine available as soon as the UA comes through. That'll probably be about a month from now. So we're getting there. Slowly but surely we're getting there, especially as we can start to inject children. That at that point we're getting into new populations. We can start to reaccelerate, hopefully, the injection rates. So that's the Michigan strategy, and I think it's a clever one, tying it to actual herd immunity levels through vaccination. We're the only state to have done this. Other states are trying to incent their populations. I'm working with Connecticut. They're giving people a free drink, which is part of the equation. It's part of the equation. Of course, for the cost of a small meal, you can the United States is actually vaccinating you for life, hopefully. And that's so it was depending on your bottle of wine and what you choose to drink, it's about a break even there. Yeah. And West Virginia's giving people $100 savings certificates. So there are all sorts of inventive ways of trying to move the equation forward. Please, let's get vaccinated.
So looking at this, originally we were talking a month or so ago about maybe a small gathering around the 4th of July. Is that feasible now or not?
Well, if we look at the governor, the answer is, if it's outdoors, absolutely. I think it is.
And then the other big thing, because I just put a deposit down on my Michigan football season's tickets, is football season starts right around Labor Day, and that's a huge crowd. You're right shoulder to shoulder. What do you think?
That's going to start more slowly, I think.
Yeah.
I think we're not. I think certainly August football, forget about it. I think just because we won't be at the ability to exercise effectively. I think that possibly by late September, possible to start doing things out again, especially in outdoor arenas. If it's indoor Ford Field, longer.
Yeah. Yeah, well, Michigan Stadium clearly is outdoors, so...
Yeah, well, Michigan Stadium, I don't think we will have that until late September, early October.
Yeah, because I think in September there's 4 home games scheduled.
Oh, bummer.
Yes, so...
Yeah, that'll be partial. I think that'll only be partial capacities.
Yeah. Well, versus 115,000 people shoulder to shoulder,
Streaming. So, streaming. Don't forget the streaming
part. Oh, the streaming, yes.
Singing Hail to the Victors. Or
yeah.
Yeah, that's not a good scene. I don't think for a while longer, especially in
Okay.
the restrooms. You remember the restroom lines? Holy cow! You have to maintain a 3 foot, even a 3 foot distance. You'd be out the door.
Oh, yeah. I mean, that would reduce it by, you'd probably only be able to get 30,000 people or so into there, so.
Yeah, it's going to be it's better to be safe than sorry in this case. You don't want to create an outbreak, yeah, and then miss a whole season because you wanted to squeeze in a game.
Well, I mean, last year they did games without people in the stands. It's
Yeah,
just now
and
they're,
that's possible. Absolutely, that's going to be
yeah.
possible. Yeah.
Now they're not giving you that option. You have to buy the tickets and they hold your money and they'll let you know whether you can get into the stadium.
I heard it was like $150, right? And
Oh,
just to find
the
it, put yourself
tickets?
on a list.
Oh, well, yeah, it cost me $400 just to say I can buy two tickets, and then the
Oh,
tickets
two
are
tickets.
$1,100, so that's a $1,500 investment.
Youch.
But
Yeah.
they, but
Well,
then,
well, it'll be a partial season. I wouldn't. I think you'll see parts of the games.
yeah,
Certainly by the end of it. Hopefully. Now the problem is starting toward the end of November when things get exciting,
oh yeah,
we're gonna be at higher risk again of having an outbreak, and I'll show you that in a second. Here's what was interesting, and one of the reasons that getting vaccinated is so important beyond just wearing a mask is that here is what happens with transmission rates. If you take and this is among households. So what they did is they looked at households that weren't vaccinated, and they looked at the person who got the disease despite being vaccinated. So it's a small N ultimately, but you can see that overall, if you got vaccinated, your chance of transmitting it to somebody else in your household, which is about a 37% chance among married people, about 20% chance among if you have children, and about a 45% chance if you've got young children that you're holding close and taking care of. Then here's the rates. Now 50% lower than that occurs after about 20. Once you start to get into that second dose, another reason why the second dose is important, you start to get 50% or better rates of getting the disease reduced. So you have a reduced rate of 50%
hmm,
versus up on top. You can see after 12 days there's no real difference, and this is pretty consistent with what we saw with the real life data. Here, you can say no effectiveness of less than 14 days, right? So same sort of impact we're seeing over and over and over again, where you really want to get the double dose. You really want to wait the full 14 days after that double dose. At that point, you really do see a reduction in transmission as well as case rate. So
hmm.
this transmission rate is something we have a lot of trouble figuring out in the United States because we don't have a national health system. We don't track this very carefully, as carefully as we need to in order to figure this out. But in the UK, they do have one, and they're watching symptomatic, asymptomatic rates very carefully in their entire population, and this is the result. So great news: 50% reduction in transmission. Remember, I told you a little bit about the fact that if you were in elderly care, that you had a bigger chance if your caretakers weren't vaccinated, you had still had a fairly high chance of coming down with COVID, even if you were vaccinated. And it turns out that the better place to be if you're elderly, if you can, is this is long-term care versus community care. So if you're in a community where you need a little bit of care, that's a much better situation than if you're in a long-term care situation with caregivers, especially if those caregivers are only 50% vaccinated, which was the case in that Kentucky example I gave to you. And then literally half of the caregivers got COVID because they weren't vaccinated, and 20% of the patients in that care facility who were vaccinated died, and 80% who weren't vaccinated died. So you can get a sense of just how important this vaccination is for caregivers in long-term care facilities. If you're in a community setting, 35% lower rates of overall chances of excess mortality.
Hmm.
So that's a much better situation if you can do it, if you're elderly, to be in a community setting than in a long-term care setting if you've got high degrees of COVID and a staff that is resistant to getting vaccinated. The other thing that was important was the fact that keeping active is important. And remember, we talked about the fact that we thought that a lot of the COVID concentration about attitudes and willingness to take the second dose, willingness to take a vaccine, were largely red states. Well, here's the activity levels, and you can see once again that activity levels in the South, in the strong South, especially in the red states, are lower. And as a result of that, you can see that if you were inactive, you had a 2.26 times higher chance of being hospitalized. And that may be because you're obese as well. ICU rates also about double chance. Deaths 2.5 times more if you were not active prior to having COVID. So not only COVID, but for all reasons you should be active. And you can. This is from Kaiser, and they were looking at patients all over the country, especially because they have both a healthcare capability as well as an insurance capability. So they actually have to monitor this pretty carefully. So you can get a sense of who's active in the United States, who's less active in the United States. And we unfortunately are in a less active state, which means we're going to have a worse situation when COVID hits. And sure enough, we're having some challenges right now. Once you get infected, you're going to have a worse situation. Here, now we're going to talk a little bit about mutations. Here's the 510. The N510Y mutation, and this is the one that makes it much more transmissible. And this is what the V117 has. So it makes it much more transmissible because than the B1 original variant. And it turns out that it causes you to have higher viral load. It infects more easily with a lower load. So you're coughing up more. Those little particles that you're coughing more of are much more infectious and require much less seeding than the B1 original, and it makes you still shed 2 weeks longer than the original. So all those things make it much more transmittable, and that's why that result with largely in a B117 environment in England with a 50% reduction in transmission, that puts us back to about normal, back to the B1 variant, because we're now fighting a different variant. The E484K substitute, this is the big one. And this is the one that's going to cause us to have to get re-inoculated. And the reason you're going to have to get a booster shot is probably because of this particular variant, the EEK variant. And that's because what we see is about a 50% reduction in overall protection with the Pfizer Moderna vaccines. Now that means that you want to get another boost against this variant because that's just going to boost you back up again and get you back to the 95% you want to be at. And this is the one that's going to cause us to have to continually go back. These kind of mutations right in the area of the domain binding motif. Those mutations we're very sensitive. The vaccine is very sensitive to, and those are the ones that are going to cause you to come back. So when you look overall, then there are two new ones: California, the B1427, 1429, and the B1526. Of these, there's the California causes you to become they're more transmittable, but the New York one is the one to watch out for, and I'll show you why in a second. Now there's a new variant called the 1617 variant, and that's the Indian variant that's causing so much death. And my projections in India is they're going to have over 1 million deaths in India, possibly as many as 2.5 million. They won't admit it because they don't track excess deaths very effectively. But if you actually had an excess death tracker the way we do in the United States, they'll be at 2.5 million excess deaths this year because of this variant.
Pouring in out of the New York one, I just saw New York Mayor Bill de Blasio saying, "Come to New York, July 1st, we're wide open." Doesn't sound like a real good idea, does it?
No. I think you'd better wait for New York. And here's why. I think on the next page, this is how fast these variants stream through our country. You can see that back on January, the little yellow B117 variant was a small percentage. It was less than 3%, right? By March, it was over 50%. And today it's almost 80%. And worldwide, it's about 90% of all infections of the B117 variant. So it takes only 3 months for these variants, if they're powerful, to come streaming through your country. And unfortunately, a vaccine takes, right now, the fastest we're going to be able to get a new vaccine against the variant out is likely to be 3 to 6 months. But don't forget, we're going to have to wait for a while till we realize that's the one we want to go after. So it's likely we'll have probably up to 3 month periods of time where we'll have outbreaks before we can get a new vaccine for that variant, should a variant break through. So we're right on the edge still for a while until we get final control of this and really drive the overall incidence of this down. That's why it's so important that on a worldwide basis we get the numbers down, so we get control of the community spread. If once we get that in control, these outbreaks will be easier to control. Right now they're not easy to control. Now here is why we're worried about the New York variant. Right, here's the UK variant, and that's coming through, and you can see that it became half of the within 3 months. It became half of the of what we had facing us in the United States. The Brazilian variant, although we've been exposed to it, doesn't seem to be as effective in transmitting, but the New York one's keeping up, and the California one's dying out. So that New York one is the one we have to watch for, because that could overcome the 117 variant, and we're seeing a much with this particular variant, 1526 variant, with the EEC mutation. There are two different variants of the variant. One has the EEC mutation, one doesn't. With the EEC mutation, we'll probably have to have boosters to prevent the New York variant spread in the fall, and that's what's likely to happen.
So how do we get Africa and India under control? Just flood them with vaccine, or what?
Yeah, vaccine and PPE is our best. Vaccine is really our best chance. We do have some protective masks and so on. The challenge with these populations is they're very, very large. I mean, India has, as I said, we're basically a rounding area in India's population figures. The United States, they've got 1.4 billion, almost 1.5 billion people.
And Africa's got to be close to 1 billion, right? So
yeah, and you can see even in China, where China, is because they've controlled the variant, they're able to go and sell their vaccine to the rest of the world. They're not injecting so many of their own people. They've only got they've got less than 3% of their population vaccinated. They're going out into the world, checking out their vaccine, then coming back to China, getting currency, getting political capital, then coming back to China and injecting their population, a year from now, 2 years from now, and they get the scale up. That's their strategy, I believe. So that's kind of what it looks like. Here is what's happening with testing rates, and we're hoping that this is the PCR testing rates, and you can see they're way, way down. And the problem with not having tests is you don't know what's going on with how much COVID you've got in the environment, and you don't have, because you don't know that, and you don't know how many positive tests. You're not actually testing those positive tests for variants, and so we're only actually looking at about 0.1% of the COVID that's in the United States is being genetically tested. And we have to get to at least 5% or 50 times more in order to really have a sense of what's really happening with the mutations. So this is on the variants. So this is a real problem. This drop. You can see in December we were way high. Vaccinations came in, and we started to say, well, now we don't have to test anymore because we have vaccines. That's not the case, and so we really have to ramp this back up again. There is a hope on the horizon, and that's personal testing at home. And here's the Abbott Binax Now. It takes 15 minutes. That's a lateral flow immunoassay. It's like the one you use for pregnancy tests. Tells you yes or no. Doesn't require a prescription. $24 for 2 tests. You have to take 2 tests because it's not as accurate as we'd like it to be. You have to take 2 tests in 36 hours. If you get 2 negative tests, 36 hours, and you're home free. EUA test is available since 2021. And here's the positive. The problem is the sensitivity isn't quite as sensitive as we'd like it to be to avoid the double test. The Lucira home test, which is actually approved slightly before Abbott, is a 30-minute test, no prescriptions. All the national chain pharmacies have it. It costs $55 for a single test. It actually uses a molecular testing capability, not a lateral flow technology. Molecular testing is actually what they use for PCR. So it actually will expose the molecule, the RNA of the virus, and look at it directly, and it does detect all the variants, and it's much more sensitive than the Abbott test, and so it only requires the single test. It's a little more expensive though. So that hopefully you'll be able to do a lot of this at home. Hopefully, if your employer wants to do a lot of exposure type of work and you're an essential worker, they'll give you some of these tests to bring home with you, so you can do it at home without exposing people on the public transportation systems. That will be ideal. So you get all these tests done at home before you start entering the public workplace. So Here is something that's sort of interesting. There's a lot of there are a lot of Marines who are rejecting the vaccine. As a result of that, what they found was that if you're at 40% of people are saying no, I don't really want to have a COVID vaccine, thank you very much. And in the Marines, or any of the military, if it's a approved vaccine, they can make you take it, right? You'll go through the vaccine tent and get shots for everything, including COVID. In the case that it's an EUA or an emergency use authorization, they can't force the soldiers to take it. And so this will probably turn over when Pfizer gets a full approval, and you'll see everyone getting the vaccine. But right now, what's interesting is that even if you have had the vaccine, if you're among a high level of people who have not been vaccinated, you've got a 10% chance of getting reinfected. And that's even after vaccination, and so that's a big issue that we're going to see if we have a lot of rejection of the vaccination. Now, the reason it's so impactful is because we're worried about the long haul effect of COVID. And you can see here's the CNS impact. And it is very much like what they call ITB. It's traumatic brain injury, TBI. So if you're a football player who's been playing in the NFL for a few years, and sadly we've looked, and every time we see a lot of traumatic brain injury as a result of playing physical sports, or if you've been in a bad car accident and so on, that's the kind of brain fog these people are having. It's as though we were having a traumatic brain injury. You can see intracranial hemorrhage, ischemic stroke increases. I mean, these are major. The blue line indicates what the average population suffers, and the red line indicates your additional risk. And these are much look at the risk of dementia almost doubling. And it's not so much dementia as it is this traumatic effect that they have in the brain that causes these fogs, causes forgetfulness, causes terrible headache, causes fatigue. And it's not only in the central nervous system, but it's also in the peripheral nervous system, and it's also in the autonomic nervous system, which causes what they call dysautonomia, which means your heart rate goes kerflooey, you get a lot of tachycardia, you can't control your bowel movements as well, a lot of diarrhea, a lot of trouble with that. All those things that you do automatically, all the things that you do without thinking about them, like breathing, all those things become dysfunctional after you've had COVID. So that gives you a sense of some of the things that we're worried about. We're also seeing mood, anxiety disorder. These aren't just issues of COVID and being shut in. These are issues of people, the brain chemistry actually changing. We're seeing that, and these conditions are occurring in people from over 9 months of COVID suffering at this point. Here is the post-COVID after hospitalization. So there is not a correlation between whether you have a very bad symptom or not. But what's nice about hospitalized COVID patients is we can track them, and afterwards you can get a sense of the control versus patients with COVID-19. So if you've been in the hospital, you've got a 50% higher chance of getting diabetes. MACE is a major cardio event. You've got a triple the chance of having that happening. Chronic kidney disease doubles. Chronic liver disease doubles as well. So those are major chronic illnesses, and you can see some of this is the British Medical Journal. 29% readmission rate, 12% die after discharge, 29% have a recurring respiratory disease, and the risk is bigger if you're a woman and over 70. And you can see new onset. Not only can you make old events worse, but you can actually create disease. And we're very concerned about how much extra diabetes is out in that population, how much extra cardiovascular is out in the cardiovascular event is out in that area, and how much major kidney damage is done, because almost every part of your body has an ACE receptor to it. Those ACE receptors are what the virus binds to. And once those ACE receptors are affected and you've got that organ hit, it then hurts the vasculature or the blood flow in that organ and starts to do real damage, and it's permanent damage. You'll live like this for the rest of your life. And that's why we're so concerned about young people not getting vaccinated, because if you're 18 and have this, you're going to have it for the rest of your life. And that'll be a disease that you can't get rid of. It'll be permanent. You can see that here's what happens to your daily life. Here are the people who are seronegative, your work life. We think that 50% of people who have these long-term COVID disease will not be able to return to work. It's a new permanent damage to chronic disease that is going to cause you not to be able to go back to work. Your home life is going to be markedly different, and your social life also, down by 50%. Each of these are down more than 50% in terms of the disease. And here's what things look like for the young. 98%, you can see 4 months post infection, 70% of these people complaining about long-term COVID. About 30% of people the official numbers in the United States are between 8 and 22%, but on an international basis, where we see a lot of this, it's about 30%, we think, overall have long-term COVID. And the issue is that if you have long-term COVID, it's very hard to get care. There is CMS, despite the fact COVID's been around now for over a year and killed 500,000 people, has yet, this is the Center for Medicare, Medicaid, they have yet to assign a number that a doctor can go and say, the person has this problem and therefore should be paid this much money. Right now, the doctors aren't getting reimbursed. They've got to find other things to get reimbursed against. And even though if they know that it's the case, we've got to train about 500,000 doctors about what these symptoms are. And so there's a huge effort that's going on right now, trying to, allow people to allow insurance, and the insurance companies, of course, are fighting it because there's no charge code for it, and they will reject you because they say this is a formerly very, this person never had any problems. Why should we pay for an MRI to decide whether they have a COVID problem now, right? So there's no reimbursement and there's no incentive for the insurance companies to pay. And that's a big problem because here are the kinds of symptoms that people are having. And we don't have a very rigorous capability to help these people yet. We have to go on EUA now for long-term COVID, which allows them to do an emergency authorization of new respiratory therapy, new cardiotherapy, and new drugs in order to really solve this problem. So that's sort of some of the things that are happening out there right now.
Wow.
Other than that, everything's great.
Yes, it's better and better.
We are getting, it's going to be a good summer. We're going to have a good summer, but be careful out there. Get vaccinated if you can. If you can't, give me a call and we can talk about some of the things you're worried about. And hopefully, we can, you'll feel more comfortable. And if that's the case, we'll talk about some of the things that people may be worried about and what to think about, how I think about those issues. Maybe next time.
And if you want more information, it's fredbrown.com. I think all of our videos are up there. I know you've been working with a partner to put those up there.
Yeah.
So we got quite a library of material here for you to take a look at. You get the whole history of the sweep of the pandemic by watching the videos, right?
That's right. You'll see everything starting March, when I was predicting it was going to be worse than we thought.
Yeah.
Well, until today, I still think it's probably going to be a little worse than we think. But it's getting better. We're on the right track.
Yeah, it's better, but there's a big but hanging in the air, so.
Yeah, we're getting overly anxious. We have to kind of.
Well, yeah, and one last thing. I was looking at the pandemic of a century ago, and in some ways it's mirroring that. People got not COVID fatigue, but they got Spanish flu fatigue back then, stopped wearing their masks, said to hell with it, we're going to go out and have fun, and then the big surge came back. So.
Absolutely, completely normal. This time we've got a good vaccine, though.
Yeah.
We didn't have one, so that's why the surge came back even stronger. If we didn't have a vaccine, we'd be up well over 600,000 deaths.
Traditional four-year students love Lawrence Technological University's thriving campus life, but LTU has always met non-traditional students' needs too. Lawrence Tech offers over 100 degree and certificate programs that can get adult students started or back on track. And most of our classes are conveniently offered evenings at our beautiful Southfield campus or online, so you can balance your social, family, and work life even while you power up your career. Lawrence Tech, where Blue Devils dare.